Welcome to our live webcast, ESP and Serratus Plane Blocks for Thoracic Trauma webinar. Thank you for joining us. My name is Elizabeth Smith, and I'm the Membership Manager for ASRA and will be the host for tonight's webinar. We are joined tonight by our moderator, Mark Leonard, CAA at Team Health in Trinity, Florida, and Assistant Professor at Nova Southeastern University in Tampa, who is going to introduce tonight's topic and speakers. Welcome, Mark.
Good evening, everybody, or good morning, or good night, depending on where you are in the world. So thank you very much, Sarah, for the introduction. My name is Mark Leonard. I'll be working alongside Dr. Reid Nelson tonight in this industry-sponsored webinar. So we want to say a huge thank you to ASRA and to PAJUNK for asking us to do this talk for you all this evening. And we're going to concentrate on two hot topic blocks at the moment in Serratus Anterior Plane and Erector Spinae. So I want to ask you if you have any questions during the presentation, if you could use the question and answer box at the bottom of your Zoom screen. Please don't type questions into the chat box. Please use the Q&A box and we will answer those questions at the end of the presentation. Feel free to chat throughout the presentation. So the chat and the Q&As will be monitored. And yeah, without further ado, we will... Sarah, if you could let me share my screen. Okay, while I'm waiting for Sarah to stop her screen, I'm just going to introduce Dr. Nelson for you. So Dr. Nelson's a board certified anesthesiologist at the Dixie Regional Medical Center in St. George, Utah. He's currently the Associate Medical Director of Acute Pain Services and Obstetric Anesthesia for Intermountain Healthcare. And as a partner for Mountain West Anesthesia, he serves on the Board of Managers as the Chief Information Officer. Dr. Nelson also volunteers his time as the Medical Director for the Dixie State University Respiratory Therapy Program, and he enjoys working with the respiratory therapy students. He's the Director of Anesthesia for the Texas Pediatric Medical Foundation, and he enjoys going to San Miguel, Mexico every year to provide nerve blocks and anesthesia for their medical missions. He's the founding partner of a healthcare software company called RX Check-In, and is currently on the company's physician advisory board. Dr. Nelson grew up in Salt Lake City, Utah, but he now enjoys living close to Zion's National Park in southern Utah. He and his wife have 5 children, with the 2 oldest girls studying at the University of Utah. He loves fly fishing and his 3 boys and his dog, Charlie. So, Sarah, I can't share my screen as whilst yours open. Thank you. Now, 1 second. I'm sorry, everybody. We had done a dry run on our presentation, which meant that I would have been sharing my screen with you on the last slide of our presentation, which you really aren't here to see. You really do want to see.
We can go backwards.
The first slide. Oh, always. Okay, everybody. So, thank you. Again, you know, I jumped on the chat earlier to see where people were from, and, you know, all across America, people in the UK, where I know it's midnight over there. You can tell from my accent that I was once from America. Australia, Serbia, Hong Kong, Mexico. So thank you for joining us, and I really do hope that you get something out of this presentation. I'm going to speak about Serratus Anterior Plane blocks with you first of all, and my experience of those, and then I'm going to hand over the floor to Dr. Nelson, who will run over ESP blocks with you, and then we will answer those Q&As, which I can see coming in at the same time. So, why are we talking about these blocks? Well, predominantly because of chest wall trauma. So this is what we're going to concentrate on a lot tonight, rib fractures, chest wall trauma, and the high mortality rate that these injuries carry. Most of these are largely due to the extreme pain that the patients are under. And for those of you that deal in a trauma environment with patients with multiple rib fractures will know those patients don't want to breathe, they don't want to take big inspiratory volumes, and because of that, that promotes atelectasis, and it puts these patients at a high risk of getting hospital-acquired pneumonias. That's not good for those patients, and especially if your patients are from the older age bracket or have got underlying respiratory pathology, that creates a problem. And traditionally, we would treat these patients using combination therapies, including opioids, thoracic epidurals, intercostal blocks, but there's problems associated with those, as we know. High-dose opioids cause respiratory depression, which further exacerbates the effects of the patients not breathing. Sedative effects, which again causes dyspnea and dyspnea, and then possibly apnea. Hypotension, and if the patients are anticoagulated, that creates a problem with any of our central neuraxial blocks. So the Erector Spinae Plane block and the Serratus Anterior block are simple blocks which can offer you equal analgesia with fewer side effects. So the reason that we're doing this presentation for you today is PAJUNK are releasing the 5th poster in their range of 3 posters. This poster covers regional anesthesia for thoracic trauma, and we can see that Serratus Anterior Plane, Erector Spinae, thoracic paravertebral and thoracic epidural blocks are featured within that poster. If you'd like to inquire about that poster, there is an email address at the bottom. I will post that email address in the chat panel, and we will put it up on one of the slides further in the presentation. So the Serratus Anterior Plane block. I couldn't teach you a faster block if I wanted to. This is a very straightforward block, practiced in a lot of ED centres and works fantastically well. So what is it used for? It's a fascial plane block. It's considerably safer than trying to place a thoracic epidural or a paravertebral block. Used for thoracic surgery, breast surgery, surgery in the axilla, which can tie in with thoracic surgery for axillary node dissections, rib fractures, predominantly lateral wall fractures, and chest drain analgesia. And these are all indications where I would insert a Serratus plane block into a patient. So what nerves are we blocking is a question that's quite often asked. Well, the main nerves we're covering are the lateral cutaneous branches of the intercostal nerves from T2 to T12 predominantly. Again, depending on the area of the block, the volumes of local use, then the other 3 nerves that can be caught are the thoracodorsal nerve, the long thoracic nerve, and the intercostal nerves, all supplying different innervation to the different muscle layers that we're talking about. Where do we perform it? So mid-axillary line. If I had a model and an ultrasound probe here now, I would tell you to take the probe in your hand, pass it into the mid-axillary line, and you would pretty much be seeing the image that you want to see from that. So overlying the 4th rib, it's very easy to identify the muscular anatomy there. And that also will give you a good indication to place the needle and get good posterior spread of that local anesthetic. Now, when do you perform it? Well, it's very easy to insert. So if you're not confident in inserting a paravertebral block, or when Dr. Nelson talks to you about Erector Spinae Plane blocks, you think, I'm not ready at that level yet, then maybe using the Serratus Plane block as an adjunct, as an alternative with multimodal analgesia will be sufficient for you. It's got a very good safety profile. So again, that falls in a learning block category. You avoid a sympathetic block, so of course that has its advantages. It can be performed in the presence of abnormal coagulation. So a patient's got abnormal coagulation, comes in as a trauma patient with bleeding issues, and this is a very safe and fast block to perform. And the patient does not need to be sat or rolled laterally to perform any blocks on the posterior side of the anatomy. So if the patient's immobilized with a neck collar and on a spinal board, you can still perform a Serratus plane block on that patient. So it has great advantages where that patient cannot be mobilized. Now you could perform a Serratus block, send the patient for CT. When the neck comes back clear, and you know that you can safely either sit or roll the patient into the lateral position, and then you may want to progress with an Erector Spinae Plane block after that. So how do you perform it? Pretty much take the probe in the transverse plane and pop it into the mid-axillary line at the 4th to 5th rib level. It's a very straightforward block. So at the level of the nipple, scan from the anterior surface posteriorly into the mid-axillary line, and we will see the ultrasound image on the right-hand side of the screen. There's quite often some little blood vessels in there underneath the latissimus dorsi muscle, which are good indicators. So they're branches of the thoracodorsal artery. And this is what we should see. And I've got some videos to show you in a second. They're about 40 seconds long, which is exactly how quick it is to find the anatomy for this block. So we're starting slightly anteriorly. We can move from a pectoralis area and scan our probe lateral, posterior into the mid-axillary line. And what we will see is the latissimus dorsi muscle coming in. Now, I describe it as a wedge, a doorstop, or a rocket coming into the screen. It's very easy to visualize. Below the latissimus dorsi is serratus anterior running across the top of the ribs. We can see the fifth rib in this image here, and the intercostal muscles running in between those ribs with pleura beneath. When we see the video, it's very easy to see that pleura is visible, and we can see the pleura moving, unless we're inserting this block for a chest drain insertion, for example, where there may be a pneumothorax. So obviously check to see if pleura is there before and after your block. Now, it's a relatively superficial block as well, so we're not going deep with our needle, and basically we're going to place it into this fascial plane beneath latissimus dorsi. So we don't want a big 90-degree insertion angle with our needle, and if we carefully insert our needle from the anterior approach, we should use the rib as a buffer. So we can have the rib in an in-plane approach. It also lends itself to an out-of-plane approach, but I do practice them in plane. This is also a fantastic block for indwelling nerve catheters, and by inserting a nerve catheter, we would need to go an in-plane approach. So here we're going to just watch a short video of the scanning for the region. So we can see we're starting off already in the mid-axillary line, and we are going to just move our ultrasound probe posterior until we come into the mid-axillary line, and we can see a rib, 2 ribs, 3 ribs, pleura beneath the ribs, the intercostals, and we see that latissimus dorsi muscle come straight into that image. Serratus underneath that, and the ribs and the intercostals in between. We can see the small blood vessels if we put color Doppler on, which we should always do, ensuring that we stay away from these vessels. Now, under hydrodissection, the vessels will collapse and move out the way. So we're going to have our needle from an anterior approach coming from the right-hand side of the screen into this fascial plane. When we inject into there, we expect to see latissimus dorsi and serratus move apart from each other, and we are injecting into that fascial plane. If you hydrodissect, as you move into that space, hydrodissect your needle, you will get better posterior spread and more coverage. So a male patient next, slightly different anatomy in the respect that he has a larger serratus muscle. So again, scanning mid-axillary line, there's that latissimus dorsi coming in. We can see those 2 thoracodorsal vessels, 2 ribs, pleura below moving very nicely, intercostal muscles, needle into this space. Remembering it's a high volume, low concentration nerve block, as with most of our fascial plane blocks. So maybe 30 cc's. You can perform this block bilaterally for bilateral rib fractures or bilateral surgeries. I do this block for all of my bilateral mastectomies and reconstructions. So higher volumes, lower concentration block. So in summary, that's my part. Why would we do this? Well, it's so easy to perform. Take the probe, mid-axillary line, look for latissimus dorsi, inject below it and above serratus. It has a very good safety profile when ultrasound used correctly. The biggest warning sign for this is to make sure that you stay away from the blood vessels. So use color Doppler, aspirate and inject very carefully. It can be performed supine, so we don't need to reposition our patient. So let's say that our surgery extended and we thought that this had good efficacy for pain relief for this block. We could do that while the patient's asleep and supine. It does not cause an autonomic block, so there's minimal side effects on the patient's blood pressure. So if we're worried about that, it's very straightforward. It's a low concentration, high volume block. So please, for all of these blocks, make sure you calculate your maximum doses per your patient's weight. and it's an excellent block to site a nerve catheter. And the PAJUNK E catheter is a fantastic catheter to use in this. It's as fast as doing that single shot block. It positions very, very well, and that catheter can stay in for several days and give good pain relief. So that's my little blurb on the Serratus Anterior Plane block. I'm going to now hand over to Dr. Nelson, who's going to talk to us about the Erector Spinae Plane block.
Great. Thank you, Mark. Appreciate it. That was a great introduction and explanation of the Serratus Plane block. Today, we're going to continue on with the Erector Spinae block. And this block has been used for multiple reasons, and it's quickly becoming more popular, mainly because of the lower side effects and the ease of placement. Go ahead and go to the next slide if you wouldn't mind, Mark. It is, again, a fascial plane block, and because of its safer profile, it has become an alternative to thoracic epidurals and paravertebral blocks. We commonly use this and are being asked to place this block for chest wall trauma, especially for multiple rib fractures. And we're going to the ICU to place these blocks, either surgical cases where they're going to be plating these ribs, or non-surgical. We've been asked, they're becoming so popular that the trauma surgeons are asking for those either way. We also do these for major breast reconstruction surgeries, major mastectomies. It's a bilateral block, but it seems to last a little longer than the PEX block, and just a local infusion or injections that the surgeons are using. A more recent trend has been our heart surgeons and thoracic surgeons have been asking for these blocks. We did one a little while ago, and for a patient postoperatively that was struggling with pain. And one of our docs said, hey, yeah, let's try this for the sternotomy. It worked so well that now our surgeons are asking for all their sternotomies and their thoracotomies to have this block. And you're also seeing some major upper abdominal surgeries that will work for this block as well. Some of your bariatric surgeries and are very popular, are becoming more popular with a lower erector spinae block. Next slide. Oh, there we go. This is a local anesthesia that you can typically use for the erector spinae block. There's multiple options here, but I'll kind of tell you how I approach this. Again, I'd like to emphasize that these are maximum doses. So if you're doing bilateral blocks, you have to include this in all your injection sites. 1/4% bupivacaine, I would say 20 to 60 cc's. Again, if you're going to inject 60 cc's, you need to make sure that it is a larger person and it falls within the local anesthesia systemic toxicity dosing. 1/4% or 0.2% ropivacaine maybe not last quite as long as bupivacaine, but is also very advantageous for those who are compromised with some other morbidities that may not tolerate as much bupivacaine. Like Mark said, perinatal catheters are easily placed in this block as well, and can be placed for multiple days. You know, we've had thoracic epidurals in for a week to 10 days, and we typically only have 5 days for a peripheral nerve block, but it is possible to have them in with good sterile technique for a little bit longer if needed. You can also place multiple nerve catheters. If you have rib fractures from T2 to T10, one nerve catheter may not be sufficient, and you may need to add one at T2 or T4 and one at T8 to cover all those rib fractures. Liposomal bupivacaine isn't a good option for this as well. It typically will give you anywhere from 48 to 72 hours. And if you need to make that a little higher dosing, you can mix that with 1/4% bupivacaine. I do like having some supplements in there, epinephrine or dexmedetomidine, and because they will give you a few extra hours if you're going to do just a single injection. Next slide. So this is where do we perform it? And I went into a little bit of this before, but typically in the thoracic and lumbar vertebral areas. Again, if you have rib fractures, you kind of want to go in the middle. The fascial plane is below the erector spinae muscle and above or posterior to the transverse process. This is a high volume injection, low concentration. And remember, you want to go at least, if you have rib fractures, you want to kind of go in the middle of that. So T4 or T2 through T6, you'll want to go right in the middle at T4. And that will get 2 levels cephalad and 2 levels caudad, typically, with a 20 to 30 milliliter injection. And again, it may require more than 1 level to inject to cover all those fractures or cover all that surgical site. Bilateral blocks are required for mastectomies and sternotomies. And this block, because it's a fascial plane block, we oftentimes perform this under general anesthesia. But it doesn't necessarily have to be. It's not a painful block to place. Awake patients tolerate this very well. If you're doing bilateral mastectomy, we'll do it before surgery to give it time and use it as part of the multimodal analgesia regimen. Next slide, please. When do you perform this block? We get a phone call all the time from our trauma surgeons asking us to come to the ICU and perform this block. It can be performed on an intubated patient if you need to, or preoperatively on an awake patient. It should be part of a multimodal analgesia regimen, especially for painful surgeries. And I would recommend it performed preoperatively in order to allow it to set up in the postoperative period. We're not so concerned about anticoagulation in these patients as we are with thoracic epidurals and paravertebral blocks. It's not as worrisome because you are able to stay away from that paravertebral space and the epidural space. It's not, like Mark said, this block is also not going to drop your blood pressure very much, if at all. And you can perform this block on hemodynamically unstable trauma patients. And you can use this, like we said, for long-term opioid-sparing pain management options, 5, 6, 7 days, even 10 days if needed. Why do we use the ESP block? It's similar analgesia profile as the thoracic epidural and paravertebral blocks, but it seems to be a much safer block. Like I said, you don't have the drop in blood pressure or the sympathetic autonomic drop. And you can perform this block over multiple vertebral levels without need of blood pressure support. Anticoagulated patients, and it seems to be easier to place than the thoracic epidural and paravertebral block. Mark mentioned this before, so I'll go over quickly. This does, rib fractures and chest wall trauma does have a significant increase in your mortality. And by blocking these, you can improve your tidal volumes, improve your incentive spirometry volumes, and decrease your pneumonia morbidity. You will also see a significant increase in patient and surgeon satisfaction, not only because you have good pain management, but because of the ease of placement. Next slide, please. Key steps when I perform this block, I prefer the sitting position, but it can be performed in the lateral position. I like to scan and mark the anatomical landmarks, so the spinous process to know what level we're at. And then I start in the lateral position and go from lateral ribs and move medial. It's about 2 to 3 centimeters lateral to the spinous process. And you want to look for the change in the bony structure from the rib to the transverse process. The rib being a kind of a round bony structure, the transverse process having a flat, very flat top to it. Clean and prep the skin appropriately, and I also use an in-plane approach, and I prefer that because I think you can guide your needle much better. I aim the needle to the corner tip of the transverse process just because it helps get that into the fascial plane. If you hit the transverse process, which is probably recommended, then I would come back maybe 1 millimeter and try your injection there. That tends to be allow your fascial plane to open up with that injectate. I'll inject, and you'll watch the erector spinae muscle peel away from that transverse process. Aspirate every 5 milliliters, and again, it's a low concentration, high volume block. So you're going to be injecting at least 20 mLs per injection. And here we'll watch the video, and we'll kind of talk through the video. It's a little bit longer than Mark, so we'll kind of walk through a little bit of this video. And this is my son. He's very thin and a very good candidate for this. Most of your patients won't be like this. So, but he does have pretty good anatomy. The first thing I'll do is, you'll notice he's in the sitting position, and as I place the ultrasound probe just in the paraspinal section, you'll see that you can see the transverse process really easily. Go ahead and mark his spinous processes at C7, T1, T2, T3, T4, and T5. The majority of our breast cancer or breast reconstruction surgeries are performed at the T4, T5 area. In fact, a lot of our rib fractures are also performed there, because we'll get some T2 fractures all the way down to T6. And so we'll typically perform a block at the T4, T5 position. You'll notice I want to start laterally here. I identify the rib. There's the rib right there. You'll see pleural lining, which is the glistening as you breathe in and out, you'll see the glistening of the pleural lining. You see the flat rib there, and the muscles over the rib. And as you notice, you'll also see the shadow. Bone is typically a bright white line and a bone shadow underneath on ultrasound. And that's how you can identify both the rib and the transverse process. Now here I'll go start moving medial, and you want to look at the transition from that rib structure to the transverse process of, and you'll see the erector spinae muscles come into view here too. So right there, we'll see the erector spinae muscle just above the flat. You'll see a really flat transverse process right there, and that band of erector spinae muscle right above that. Here's the top of the erector spinae muscle, and then you see those longitudinal striations, because that erector spinae muscle is going along the in plane to the transducer. There's the bottom of the erector spinae muscle, and that go ahead and identify this transverse process with the shadow. You want to identify the erector spinae muscle, and you want to identify the pleural lining right down in here, obviously avoiding that as much as possible. And I use an in-plane approach, and I'll come up into the corner. You'll see my approach here in just a minute. But this erector spinae muscle is very well visualized above that transverse process. And as you come in, you'll come in from the side, and I always start cephalad and come down, and I just prefer that, and I find it's easier. Here, that will be the direction of the needle, and I'll go in and hit that transverse process. Maybe if I can inject at that transverse process initially, I'll come back about 1 millimeter, and that seems to be right in that fascial plane. That bottom of that the erector spinae muscle, and just over that transverse process. And you'll see that muscle peel away from that transverse process, and that injectate will go cephalad and caudat, which indicates you're getting a good block. Now the local anesthesia will spread underneath and get into possibly the paravertebral space, and spread caudat and cephalad to cover the dorsal and the ventral rami spinal nerves. And if you're going to do multiple injections because of multiple rib fractures, you'll want to come down here. And I want to show you the more posterior or the more caudad version of the Erector Spinae muscle or Erector Spinae block. We start lateral again, identify the rib, and then move medial. The Erector Spinae muscle down here is much thicker than up in the T4, T5 area. And you'll see good lateral striations here. You see the bottom fascial plane of the Erector Spinae muscle, and you can go ahead and take your needle and go in plane approach and do the exact same thing. Inject local anesthesia, again, a high volume, low concentration. And you'll also want to witness, make sure you're looking for the pleural lining, which is about 1 centimeter away from where we're actually injecting. So it's a very safe and straightforward block. And then if you're doing bilateral blocks, you'll need to switch both sides. Again, if you're doing bilateral multiple rib fractures, you'll have to do both sides in 2 different locations. So you just need to make sure that you're giving the right amount of local anesthesia. You don't want to use all your local anesthesia in one spot if you have to give multiple injections. Here's a couple still pictures just to show the trapezius and the rhomboid muscles on the left. You'll see the needle go through those, and then the ESP or Erector Spinae muscle right there, and the transverse process is about 3.5 centimeters deep. You'll see my needle just at the edge of that, and after I injected is on the right-hand side, and you'll see local anesthesia that has spread above the transverse process and below the Erector Spinae muscle. That dark fluid is the injecting from that injection of the ESP below the ESP fascial plane. Next slide, please. This is a couple more pictures. I just wanted to show the bone shadow here and the Erector Spinae muscle is very prominent here, and you can identify bone easily with an ultrasound just because of that bone shadow. Something that will really help you. Again, you want to identify the pleural lining, the bone shadow, and that ESP longitudinal striations of that ESP or the Erector Spinae muscle. The one on the right I wanted to show because I thought this was going to be a very easy block. You'll notice the transverse process is at 2 centimeters. This was a very thin patient, a rib fracture patient, and I thought this would be a slam dunk. And I put the probe on and immediately realized this is going to be a very difficult block. He'd had chest tube placed and had, for some reason, had a significant amount of subcutaneous air and emphysema just under his skin, and it caused a lot of artifact. And then you'll notice all that air up in there really caused my ultrasound probe to not visualize the transverse process very well or the Erector Spinae muscle very well. I was very disappointed that I wasn't able to get a better picture here, but you still can do it. I was able to place this block and he did really well, but just know that that is one of your complications or problems if you're going to do a patient ESP block on a patient that has posterior rib fractures. You may encounter some subcutaneous air, and you may also have some significant edema and bleeding back there. You may want to have both curvilinear and a linear probe in case you need to go a little bit deeper and get through some of that tissue. Next slide, please. Just a summary of what we talked about. We found that the ESP and the Serratus block are safer and easier blocks for our chest wall trauma, as well as our surgical trauma in surgery. Again, it's a low concentration, high volume block. We typically at least 20 mLs per injection site. If you're only doing one side, and say you're doing a unilateral breast reconstruction, I would probably inject 30 cc's of 0.25% bupivacaine and add an additive or place a catheter in that T4, T5 level. If you have multiple rib fractures or have, you may need to inject at 2 different levels. And again, the key here is to start laterally and move your probe medially about 2 to 3 centimeters paramedian, so lateral to the spinous process, until you see that flat bony structure of the transverse process. You want to peel that erector spinae muscle away from the transverse process. You want to notice your depth where that transverse process is. You want to notice your needle, your muscles, and definitely identify the pleural lining, and so you can avoid that and know how deep it is. I think that's all I have, Mark. Here's again the poster that PAJUNK has put out that for both, well, all four. It's the Serratus Plane is the top section, the ESP block is the middle section, the paravertebral block, and the thoracic epidural, all for chest wall trauma. It's a very good poster that it can explain things very clearly.
Thank you very much, Dr. Nelson. So we are going to go to our questions now. I'm going to stop sharing my screen so that we can see the questions. I made some notes of some questions whilst we were doing the presentation. And I think the first question, Dr. Nelson, that I'm going to ask you is when you place your ESP block, so from my point of view and for those that have joined us tonight, do you place this block preoperatively in the OR or in the block room, or do you wait post-operatively to place this block? Oh, you're muted, Dr. Nelson, sorry.
Sorry. I like to perform these blocks in the preoperative setting for surgical multimodal analgesia reasons. You can block a lot of the pain pathway with these cases. Even in sternotomies, you're going to anticoagulate some of these patients during the surgery, and this would be a perfectly safe block to do before or after. We've had surgeons not want to do it beforehand, and we've done it after, or most of them now are so comfortable with this and have found that it doesn't take much time to do. Patients really tolerate it pretty well too. A lot of blocks they don't tolerate very well, like a tap block, for instance. Pushing through that abdominal wall can be kind of painful. This doesn't seem to have that same problem. We do this preoperatively all the time. But then the other most common reason to do this is rib fractures in the ICU. And so we'll go there and do that on intubated and unintubated patients. And if they're unintubated, not intubated, we'll actually have them lie to their side or sit up. And that seems to be tolerated pretty well.
And another interesting question, can the ESP block be used for lower abdominal or even down as low as the hip?
It has been discussed, and I've seen a few papers that have talked about that. I saw one that was a pediatric case for a femur fracture, and they used that in the very lower portion of the lumbar region. I think what you're doing in that case is that you're trying to block the lumbar plexus as it comes off, and so I think that's a site that options that are still in research and need to be looked into, but that is a promising area. Whether you do an ESP block or a quadratus laborum block, both of those blocks are promising to have. The benefit of having abdominal ESP blocks is that you're getting some visceral and somatic pain coverage in that area. So where if you just did tap blocks or rectus sheath blocks, you're not getting any visceral coverage there. But an ESP block in the lower abdominal or even upper abdominal wall will give you some visceral pain coverage too.
Okay. So there was a question about evidence related to ESP and serratus plane blocks in relation to paravertebral and thoracic epidurals, and I think I will kind of start that off and say that there's evidence is starting to come out over the efficacy of these two blocks. There's a large trial going ahead from a team in Coventry in the United Kingdom, led by Dr. Hillerman, that's looking at their Erector Spinae Plane blocks, and pretty much they've gone away from doing the majority of their posterior blocks, and they're getting very, very good results. They will be publishing their data pretty soon, but we could spend a lot of time talking about all of the evidence that's out there. A quick Google will give you a lot of the evidence. Obviously, Rafa Blanco was the first person to describe this, the latissimus, the Serratus Anterior block, sorry. So there's some good evidence and some good trials out there. So, but we won't sit and discuss every single piece of literature out there for these.
And Mark, may I make a comment on that too? These are fascial plane blocks, and so like any of your fascial plane block, you're not identifying a specific nerve. You're not identifying the brachial plexus. You're not identifying the femoral nerve or the popliteal sciatic nerve. And those blocks tend to be very efficient and very effective because you're actually seeing that nerve, you're bathing that nerve with a local anesthetic. You can almost get complete coverage in a shoulder block with a good brachial plexus interscalene block. Fascial plane blocks, you're not identifying a specific nerve. So it's not going to be as reliable as some of these other blocks. It may not be as reliable as the thoracic epidural, because the thoracic epidural, you're getting good coverage, but you're getting bilateral coverage. You're getting a lot of side effects of that thoracic epidural and restrictions of that thoracic epidural with anticoagulation that you don't have with the ESP block. Fascial plane blocks don't seem to be as reliable, but that's why you use a high volume, low concentration. You're trying to cover as much of that fascial plane as possible, but they do seem to be a safer block to place and a much easier block to place. And that's why I think they're becoming more popular in their usage and replacing paravertebral and thoracic epidurals.
I would agree. So another one of the questions which was interesting, and it's kind of in a two-part, was the duration of action for Serratus Anterior Plane compared to the ESP. And again, from a Serratus anterior plane block, a single shot block in my experience has about 12 hours worth of duration, which is why an indwelling nerve catheter lends itself excellently for these nerve blocks. Now, if it's for complex chest trauma and rib fractures, your patient's going to be very happy for 12 hours, not so happy after that 12 hours. So by inserting a nerve catheter into these patients would almost be the norm from my point of view, as opposed to just that single shot block for chest trauma. And again, running that catheter on a bolus system as opposed to a basal flow rate. So remember, we keep reiterating, these are large volume, low concentration. So you need large volume. So if you have to dilute your local anesthetic agent down, then that's what you need to do to keep within the guidelines for toxic volumes per kilograms of weight. So nerve catheters, we would then have our team go around and either bolus them, or if you're privileged enough to have pumps that can give boluses every 6 hours, then giving a larger volume of that more concentrated local anesthetic. But consistently, a single shot block would give you around 12 hours worth of anesthesia. How about the ESP, Dr. Nelson?
Yeah, we may have a little bit longer time period until it wears off. Again, I like to add 20 mics of Precedex or dexmedetomidine to the single injections. Catheters here work, again, are a fantastic option, and we place several catheters in our multiple rib fractures. And you can even have one pump Y-pieced into 2 different levels of those blocks, and you can get multiple days with those. The liposomal bupivacaine is an option here too that will tend to get you 2 to 3 days worth of a block. But you do have to dilute that down with a 0.25% bupivacaine is what I'd recommend. If you're going to do a single injection, I would definitely add, some epinephrine or some dexmedetomidine in order to prolong that block as long as possible. But if you were to ask me what my choice would be, it would be a catheter.
Okay. So another question regarding the serratus block was whether or not you do a superficial or a deep serratus block, and there's certainly been some evidence going directly beneath latissimus dorsi and above serratus, and then going below serratus. And there's a few questions in there asking, which one should we do? Well, all of my blocks I do as a superficial serratus nerve block. I think some of the evidence leads that the superficial gets a longer duration of onset, and the efficacy between the two, there's no difference in the efficacy between a deep and a superficial block. My rationale is why risk going deeper? The deeper you are, the closer you are to pleura. If you're using an out-of-plane technique and not necessarily seeing the tip of your needle, you're leaving yourself reasonably exposed. So I only ever do superficial serratus blocks, and they work fantastically well for my patient group. Anything to add on that, Dr. Nelson?
Yeah, I think if you're going deep to the serratus anterior muscle, you're doing more of an intercostal block, and those tend to not last very long at all. And that's probably where you're getting a lot of that coverage. And for the ESP block, I have heard of some people going above the erector spinae muscle as well, but the majority of people now are going below the erector spinae muscle and above the transverse process. May I add on there that there are some the new research coming out that looks at lower lumbar erector spinae blocks for posterior spinal fusions. And I think that is promising, not necessarily because you're blocking the spinal nerves that come out of the lumbar area, but you're blocking the dorsal rami muscles, and you're actually numbing up the erector spinae muscles and relaxing them, because a lot of that pain in the lower back is from muscle spasm. And I suspect that's what it's coming from. It's not being used routinely at our facility, but I think it's an up and coming option, and more research will show if that's effective or not.
Okay. So another good question: do either of these blocks have a role in the context of chronic pain management?
Yes, they do. If you're having chronic pain, you can use these blocks as well. And I'm not a chronic pain doctor, so I have not used it for chronic pain, but my understanding is that it can be used for chronic pain of the chest wall and breast surgeries especially.
Okay. So there's a question about improving the corneal cranial spread with the local anesthetic here, and somebody said that they find the plane easily, but it seems easy to hydrodissect, but it rarely appears to spread more than a couple of rib spaces. And again, that could be, I don't know what volumes of local you're using, but again, the higher the volume, the more spread that you will get. So it's important to have that high volume, low concentration. Another thing that I really like to do as well is try and get my needle as posterior as I possibly can. So quite often when I'm scanning and looking for latissimus dorsi, I will actually have the base of my probe, the heel of the probe, actually resting on the table, on the operating table or on the patient's bed, and trying to insert my needle as far posterior. I find that I get much better caudal cranial spread and as well as posterior spread, which tends to give me, I think, a little bit better efficacy from my Serratus Anterior block.
Yeah, Mark, this is, again, both of them are a fascial plane block, and you're attempting to get in that fascial plane. I have no idea whether it's worthwhile or not, or if it works, but once I inject a large volume, I'll actually massage the area a little bit and try to spread that around that fascial plane a little bit. It's all anecdotal, but that's something I do just to see if I can spread that along that fascial plane.
Okay. So just as a reminder, everybody, we've got a couple of minutes left. I'm just scrolling through the Q&As and we'll try and get as many as we can done. But I'm sorry to anybody that we can't answer your questions. We'll try and get as many done as possible. So somebody asked, we keep saying that it's a high volume block and they use 30 cc's per side for an ESP block. Are you injecting more than that? And no, 30 cc's tends to be my maximum amount of local, and I will dilute that down to 0.25 or less depending on the size of the patient. I've got no problem with diluting that down, and as Dr. Nelson has said, adding some Precedex into that again improves the efficacy of that block, so that will always help if you're using a lower concentration. What concentration do you like, Dr. Nelson?
Yeah, it all depends on the number of rib fractures or the surgery. If it's a single-sided ESP block for, say, unilateral mastectomy, 20 to 25 cc's seems to be at the T4, T5 level, seems to be sufficient. But if I have multiple rib fractures on a hefty guy, I'll do 25 at the T4 level, and then even 25 at the T8 level, and in order to cover T2 through T10. But I may add that that's 0.25% bupivacaine. If you need a little more volume and you're worried about local anesthetic toxicity, you have a little more leeway and improved cardiotoxicity with ropivacaine. And you could use 0.2% ropivacaine and use a little higher volume with that. Again, if you want to do that as a single injection, you could add Precedex or even place catheters and run ropivacaine as an infusion for your catheter. And I would run 0.2% ropivacaine as a catheter infusion. That's what I typically use.
So there's been a few questions about citing these blocks in patients that are anticoagulated, and our thoughts on that. There was a question saying, do we go against the ASRA coagulation guidelines when we're doing especially ESP blocks? Somebody mentioned that the ESPs in principle are paravertebral, which I would contest that. You need to go through the superior costotransverse ligament in order for it to be a paravertebral block. So, I mean, as I said in my presentation, and I know you, Dr. Nelson, said the same, I will do a Serratus Anterior Plane block in anticoagulated patients, being mindful of looking for those vessels. That's the most important part, using color Doppler, hydrodissecting around those vessels. I'm more than happy to cite those blocks as a fascial plane block. Your thoughts?
And I feel the same way. I think you may have some paravertebral spread into the paravertebral space, but you definitely don't want to go into the paravertebral space with a fascial, with the ESP block. And so I think you're okay doing this in a anticoagulated patient. Mind you, if they are very anticoagulated with an INR in the 10 or something like that, then I'd be very, very careful and not to go too deep, and make sure that I can see that tip of that needle very carefully. But with a mildly anticoagulated patient, I think this is perfectly safe and a block to do.
Good. So we've had a few questions about nerve catheters, and I'm glad people are asking about nerve catheters. And would you advocate inserting a nerve catheter in plane, out of plane, fixation methods? Some people saying that they don't have access to dedicated nerve catheters, and is an epidural catheter sufficient to place into these fascial plane blocks?
I do like the nerve catheters. I like the whole concept of a catheter over needle combination. I think those work the best, but you can use an epidural, whether it be a 2E or whatever, and place an epidural catheter in this area. You don't really know where that catheter is going, and so that may not be as efficient as a catheter over needle technique. I always use in-plane. I just think in-plane approach is safer because you're watching that needle the entire way, and I just find that as a preference. I know people do out-of-plane approaches, but I just think the in-plane approach is better for me.
And I would agree. So all of my catheters I insert in plane. I also use a catheter over needle approach, and you want to run that down that fascial plane. So you ideally want that running longitudinally down the fascial plane. If you come out of plane, one, you don't know in which direction that catheter is going to go, whether it's going to go caudal or cephalad. So running across that and running it from an anterior to a posterior, especially in the Serratus Anterior block. And I find that I use a slightly larger catheter than I would do a single shot needle, and that way then I can hydrodissect and insert my catheter as far posterior as I can get. Now that alleviates any of those problems with that catheter dislodging out of that plane if you try and run it down as far as you can. So but you know, if all of you've got is epidural catheters, then by all means use those. Try and feed that epidural catheter down. Obviously the problem with it exiting out the end of the TUI needle and trying to run that down serratus rather than it flip on itself. But you know, where there's a will, there's a way, and manipulation of the needle can make that move. No. Could you just reiterate how much Precedex that you use, Dr. Nelson?
20 to 30 mics per injection. So if I'm doing bilateral injections, I'll use 20 mics per side. But then usually no more than 40 mics total.
Okay, and that will prolong the duration of the block by approximately what time?
Yeah, I think you'll get 2 to 6 hours prolongation of that block, maybe even more. But I like Precedex better than clonidine or dexamethasone, and I even like it better than epinephrine. But epinephrine is an option too to prolong that block.
So we are almost, or we are at 8 o'clock now. So we're going to wrap this up. I want to thank everybody from around the world for joining us this evening. Thank you, Dr. Nelson, for your excellent presentation. I hope this has helped some of you either learning this block or certainly giving you a different block to do for patients that are going to benefit from this. The presentation will be posted on the PAJUNK website. So if you would like to go to the PAJUNK website and revisit this presentation, you're more than welcome to. Remember, the posters can be requested via info@PAJUNK. So again, via the website, have a look on there. On behalf of ASRA and PAJUNK, I want to thank you all for joining us tonight. This concludes today's program. Thank you very much, everybody, and have a pleasant evening.
Thank you.